Well, good afternoon, everyone, and welcome to today's RCSLT webinar on dementia and the role of the speech and language therapist. Thank you very much for joining us. My name is Munn, and I'm the Director of Policy and Public Affairs here at RCSLT. I'll be chairing the webinar today. I'm joined today by two experts, Mary Heritage, who's a speech and language therapist and is based in Derbyshire Community Health Services NHS Trust, and Sasha Wade, who until very recently was Service Improvement Lead for Dementia at the Kingston Hospital NHS Foundation Trust. Just a bit of housekeeping. You can hopefully see in the right hand of your screen a function called chat. Please make use of that to send in chat messages, preferably on the subject of SLT and dementia, but if you want to use it for other chat, there's nothing we can do. And also to send in any questions you have using the Q&A button. We've had a number of questions in advance, and we'll deal with as many of those as we can, but please do send us in any further questions as we go. Just to let you know that the event is being recorded, and you can see the web address there to see recordings of previous webinars. Vicky Harris is a colleague of mine here at the Royal College. You won't hear her today, but Vicky is very important because she is running the show technically. And if you've got an issue with hearing or seeing or anything else, then you can email, so you can chat with Vicky directly, and she will help you out. Okay, what are we going to cover today? Well, we're going to be talking about the pivotal role that speech and language therapists play in the dementia care pathway. We're going to be looking at the type of outcomes that commissioners, for those of you who have them, and decision makers in other parts of the UK, what outcomes they want around dementia. We'll discuss key points from the new RCSLT dementia position paper. We'll look at how we fit into the multidisciplinary team, delivering care and support to those living with dementia. And finally, we'll mention RCSLT's Giving Voice for People with Dementia campaign. So, I'd now like to hand over for an overview with particular reference to RCSLT's dementia position paper to Mary Heritage. Mary.
Thank you. First of all, I'm going to start with some facts and figures about dementia and its context in the UK. This slide shows the number of people that are currently affected by dementia, and the figure at the bottom for England should read 665,000. So you've got the numbers for the current number of people affected by dementia, and then we see that that number is expected to rise from current 800,000 in the UK to 1 million in just 7 years. So this is something that's going to affect all of us professionally, and for most of us, ourselves or our families in the future. Not just a problem for older people. We know that there are at least 17,000 people under the age of 65 who are affected by dementia, and that's considered to be likely to be a significant underestimate. And the incidence of dementia in adults with learning difficulties is quite significantly higher than in older people in our general population. So what is dementia? Well, it's not a single disease process, it's an umbrella term, and it's always a progressive condition. We're talking about a set of symptoms that includes memory loss, mood changes, and problems with communication and reasoning. And these symptoms occur when the brain is affected by diseases. Alzheimer's disease is one, and changes caused by vascular disorders is another. We need to remember that each person is unique. They have a unique brain, and so dementia will affect them in a unique way. And our care needs to be tailored to reflect that. There are over 100 different forms of dementia. Alzheimer's disease is probably the most well known, followed by vascular dementia. And each of those, or a combination of the two, account for around 90% of all dementia. But speech and language therapists may have a higher proportion of the rarer forms of dementia associated with Lewy body disease, frontotemporal dementia, semantic dementia, primary progressive dementia, Pick's disease, and so on. These rarer forms often present initially as a language impairment, and so you may find more of those on your speech therapy caseloads than other professionals do. Now going to look at what the decision makers in each of our 4 nations are focusing on they're understandably concerned about the challenges that the increasing numbers of people affected by dementia present to us as a nation. First slide shows the position from the Department of Health in England, and the focus on outcomes that we're looking at are about early diagnosis and intervention, about improved quality of care for people who are in our inpatient beds in hospital, the very high number of people who are living with dementia in our care homes, and the sort of quality of life that we're able to provide for them. And there's a real challenge around reducing the use of antipsychotic medications for people with dementia. Looking briefly at the Scotland's dementia strategy, this has some similarities but also has an increased focus on dementia-friendly communities of participation and involvement of people with dementia and their families and carers. All the nations have their own strategies, and we've just shown you two of those here today. So how can a speech and language therapist help people with dementia and their families? Royal College of Speech and Language Therapists has produced its updated dementia position paper to address these issues, and on this slide you can see there's a link to read the position paper in full. In summary, the areas that the position paper focuses on is that speech and language therapy services should be adequately resourced to provide quality care for people with dementia. But communication and swallowing are the responsibility of the whole team, but the specific role of the speech and language therapist is empowerment and education, as well as providing a direct specialist intervention where appropriate. And early access to speech and language therapy is crucial so that people with dementia and their families can have their needs met in the most timely way. In a multidisciplinary team, speech and language therapists are really well placed to deliver outcomes for people with dementia. We'll look at those now. Firstly, around diagnosis, we're skilled at providing specialist assessments to identify the language disorders in order to inform the differential diagnosis, particularly for people where their earliest presenting symptoms are around language and communication. We can provide specialist assessment for eating, drinking and swallowing problems that are occurring, with a particular emphasis on the environment in which people are eating and drinking. And we may be involved in helping to assess the person's capacity to consent to treatment and care. On to care, we may be providing individual programs to maximise function, and that might be at any stage in the progress of dementia, and providing advice on what is the optimum environment for the person to communicate in or to eat and drink in, and looking there at what are their strengths, what are their remaining abilities, and what do they need. Living well, we'll be working very closely with the people that support the person with dementia, the carers, the family, the professional carers, and perhaps adopting a conversation partners approach or an enabling approach, as well as maybe acting as an advocate for the person with their communication difficulty, and supporting the person with dementia in their interactions in their community, making sure we're maximising their participation and their quality of life. And then helping the person with dementia and their carers by providing support that enables carers to provide care. So that might be maximising their knowledge, their skills, looking at their quality of life, the pressures that they're under, and reducing their isolation and risk of mental health problems. We'll be looking at management strategies for people who are experiencing eating and swallowing difficulties. And in this early pioneering stage of speech and language therapists' input into dementia care, really important that we're involved professionally in developing clinical networks, in influencing policy development, risk management, complex ethical decision making, and audit and research. The position paper looks at what are the risks of not providing speech and language therapy. And there we look at decreased quality of life and quality of relationships affected particularly by communication breakdown, delays in getting a good and early and accurate diagnosis in order to access the right care and our professionals, making sure that we're preventing increased dependence at too early a stage, and preventing people with dementia from being excluded from decision making about their own care and decision making about service planning. And of course, in relation to dysphagia, we're looking to prevent avoidable deaths and hospital admissions that might be in relation to nutrition, choking, or aspiration pneumonia.
Thank you very much, Mary. That's an excellent overview. If you have particular questions around what Mary said, hold those and we will deal with them at the end. Now, I'm very pleased to introduce to you Sasha Wade, and Sasha's going to talk to us about how speech and language therapists can help people living with dementia.
Hi, thanks very much for having me. So for the last 18 months, I've been the Service Improvement Lead for Dementia at Kingston Hospital. And for about the last 6 months, I've also been the Therapeutic Activities Lead for patients with dementia at the hospital as well. I'm going to talk to you a little bit about some of the ways that I've helped people with dementia at the hospital. Mary's just gone over some of the points from the RCSLT dementia position statement. Just to review, we help to inform differential diagnosis, optimize communication and swallowing, training and education, and research and development. So my experience primarily comes from an acute care context. I'm going to provide you with a few examples of some of the ways that I've been involved with the hospital. Dementia education, promoting person-centered care, supporting carers, and advocacy. So starting with dementia education, I was involved in creating a dementia program at the hospital, which aimed to deliver an education program to improve care for people with dementia to members of staff throughout the hospital. So we targeted departments that included clinical staff and non-clinical staff. So our clinical staff included allied health professionals, nurses, junior doctors, members of our MRI team. Non-clinical staff, some examples included our receptionists, our porters, our hosts and hostesses who delivered food and drinks to patients at mealtimes. So most of the dementia awareness education sessions were quite broad, and they focused on teaching staff to recognize dementia, to understand what it is, the different causes of dementia, how prevalent it is in the hospital. Approximately over half of our patients over the age of 75 had a confirmed or unconfirmed diagnosis of dementia. And of course, in these presentations, there was a lot of emphasis on communication because good dementia care is about good communication. And the training frequently also addressed how to manage behaviors that challenge, or in other words, behavioral and psychological symptoms of dementia. And I found that it helped to provide specific examples of scenarios that a specific staff group might run into. So for example, if I was doing a presentation to our porters, sometimes it was helpful to do a role play and have someone pretend to have dementia, someone who didn't want to, for example, get into a wheelchair to be transported, and just teach some of the communication approaches and strategies that staff group may find potentially useful. Dementia education also included a lot on feeding, swallowing, and mealtime promotion. We had a dining companion program, which was both for staff and for members of the community. It was a volunteer program to assist patients with dementia to eat their meals. So some of these patients had dysphagia, and some just needed assistance prompting a social partner during their mealtime. So that was another program that I was heavily involved with developing and delivering. And I also just wanted to point out that across all of the various dementia education sessions, I always made sure to advocate for the speech and language therapy profession. I always started my presentation explaining that I was actually a speech and language therapist, and a little bit about my background and why speech and language therapists have a role to play in dementia care. Okay, I also wanted to touch on person-centered care a little bit as well. So person-centered care focuses on the importance of the unique wishes and needs of the individual's care. So we're moving away from a medical model more towards a person-centered care model where the patient is at the center of care. Their needs and wishes are important, or the most important. And if we're unable to facilitate communication with patients, we're not providing person-centered care. So just a few examples of some of the programs that I was involved with to promote person-centered care in the hospital. First is the Forget-Me-Not scheme. You'll see a forget-me-not flower in the top right of your screen there. And essentially, we just use this flower to indicate whether or not someone had a confirmed or unconfirmed diagnosis of dementia in the hospital. So the flower would go above their bed or on a patient summary board on the ward, and this would just help staff to realize that they need to take a special approach with that particular patient. You'll see also This Is Me. This is another document that we promoted in the hospital. This is an Alzheimer's Society document, and it's probably the most widely recognized sort of person-centered, personal summary document that you'll probably see throughout the community and acute care. And it summarizes the person's communication methods, their daily care plan. You can indicate things that the person enjoys or things that agitate them. So it's a really useful document, and we suggest that all of our patients bring this into hospital and just update it as things change. And make a photocopy to leave with the hospital and add to their file. Okay, another few examples are Dementia Champions, environmental modifications, therapeutic activities program. Okay, so I'm going to give you a closer look at a few of these. My last bullet point is a team effort. I'm going to give you an example here. Oh, and the picture showed up a little bit backwards here, but you get the idea. So this is some of the signage that I worked with a group of multidisciplinary colleagues to update the signage for our toilets and showers on ward. So we had members of our estates team helping to find something that we could easily put up and take down if we chose to paint the doors, to do a further environmental modification later on. We had geriatricians, looking at different options for signage and sort of voting on what they liked the best. We had our occupational therapy department input on, what color background would be easiest to see, and what color font, and how, a red border could highlight the signage. And then, of course, coming from a speech and language therapy perspective, my suggestion was use of real pictures of the objects rather than sort of line drawings or diagrams would be easiest for patients with dementia to understand. So that's one project. Okay, something else that we implemented at the hospital, which is very similar to the This Is Me document that I showed you a couple slides back, which was the Alzheimer's Society document. And this one is called Important Things About Me. And this is just the front and back sides of the card that you're seeing. It's a tabletop card that folds in half and kind of sits next to the patient's bed at their bedside. And you can see from the couple slides that I've shared with you here, you can indicate what that person likes to be called, information about where they came from, things that happened in their life. Lots of good information there to get a conversation going and establish rapport with the patient. And then also on the back of the card, things I need to help me to communicate. And you'll see there that communication aids with some tick boxes are listed there. This is a really important document because it helps staff to provide person-centered care. It helps them understand what kind of approach they need to take with the person and how to connect with that person. Okay, my third example here is the Therapeutic Activities program, which is a relatively new program at the hospital, which included an education component, and it included daily one-to-one and group activities utilizing the help of both volunteers and staff members, such as rehab assistants, healthcare assistants, and we also had a therapeutic activities assistant as well. And most of the activities were communication-based. And if you have an opportunity to get involved in a program like this, I highly recommend it. It's really a lot of fun, and I think the patients get a lot out of participating in the program. So we did things like reminiscence therapy, singing for the brain, group reading, finish that line, and other familiar, interesting, function-appropriate activities. Something else that I did for the program was create a how-to guide, so that if someone was wanting to conduct an activity and they weren't too sure how to go about doing it, the how-to guide would provide suggestions depending on the person's kind of cognitive communication level as to how to adapt that activity. Okay, next, a couple things I was involved with in supporting carers. So a person with dementia and the carers are a package unit. If you're going to help the person with dementia, you're going to be helping the person who's taking care of that person with dementia as well. So a few examples of things that I did to help support carers while I was at Kingston Hospital: providing training to carers informally about compensatory strategies, function-appropriate activities for their family members in hospital, education around behavior management, communication support. Very often I would invite carers along to the therapeutic activities group so they could learn some strategies practically. Of course, advanced care planning is another example, so providing information about the swallowing decline that's associated with the progression of the disease. You'll see an example on the right there of a carer's passport that we use that basically said that carers can come to the wards at any time to support staff and to support, obviously, the person with dementia in the hospital. They know the person better than anyone else, and visiting hours and mealtime hours, that kind of thing, don't apply, is essentially what it means. Also, assistance with dementia navigation support. So just being aware of what kind of programs are available in the community. You'll see a sort of the front cover of the information booklet that we would give to carers of patients with dementia, with a phone number there that they could call to find out what kinds of services are available to them, because we served 5 different boroughs, so it was quite tricky to know exactly what was available depending on where the person was from. Finally, advocacy. So these are a few of the different organizations and initiatives that I was involved with. So I helped in creating a community dementia action alliance in Kingston. I became a dementia champion, which is for Dementia Friends, and Dementia Friends is essentially a social movement to create dementia-friendly communities. Barbara's Story is a wonderful training program for staff that was created at Guy's and St. Thomas's. It's a series of films about a person with dementia and their journey throughout sort of the end of life. And then also Dementia Awareness Week. There's a lot of different ways that you can become involved. I delivered Dementia Friends sessions as part of Dementia Awareness Week, and also had the Alzheimer's Society and Age Concern Kingston come into the hospital and display alongside me in the main entrance information about dementia.
Okay, thank you very much, Sasha. That was fascinating. As I say, we'll come back to questions to all of us at the end. Just briefly now, before we move on to questions, just to link in the RCSLT's own dementia campaign, giving voice for people with dementia. We've been aware for a while, and some of you will remember the work we did around promoting awareness of the role of SLT in criminal justice, for example. And we're aware that dementia is a similar area, which is important, is growing, but there perhaps isn't as much awareness out there of the role that speech and language therapy has, and with dementia being both politically and socially very important, we thought the time was right to raise awareness about our role. So the key objectives we have, linking in obviously to the position paper, are around budget holders reviewing provision of SLT, around care services and also the care home sector, thinking about communication and SLT, working with different professionals and staff to understand the impact of communication, and making sure that people are able to identify the early signs around eating, drinking and swallowing. We run different campaigns at different times. You'll all be aware of Giving Voice, I hope. Some of you will also know about the international campaign we're running. Although we have a general audience, I think for the dementia campaign, we are particularly focused on our fellow professionals and the awareness of other people in the health and care field around the SLT role. There's a role for everyone, and we've taken through, and those of you who are interested can find this afterwards, but we've taken the 3 areas that we can assist with around diagnosis, around dysphagia, around communication, and we've thought about different ways that we can focus awareness raising and campaigning activity. And there's things we want to do, and we have a question about this which I'll come back to. Clearly, those of you directly involved in dementia services or involved in adult services more generally will be close into this, but actually there are things that all SLTs and students can do to raise awareness, and we'll come back to that in the questions. There are campaign resources available. You'll find on the Giving Voice website a menu of campaign ideas for different people to do, a leaflet that you can use in awareness raising stalls, for example, in your hospital foyer or whatever, but also a slightly longer briefing that if you were to meet with the MP or you're to meet with the chief executive or whoever it might be, a longer briefing that you can leave behind for them. And we also have a specific awareness poster built on the 7 signs around the communication signs there can be around speech language therapy and dementia. So we hope we'll make use of all of those. There are the links, and when this goes up online, you'll be able to find all of those. Let's move on to questions. As I mentioned, we had quite a number of questions that have already come in, and so I'm going to begin with a couple of those which were around the area of access to services, I would say. First of all, somebody asked whether people were having difficulty working in areas where historically speech and language therapy was only involved for people with dementia and dysphagia. And secondly, an allied question around speech and language therapy services not accepting referrals for people with dementia and whether that might even constitute discrimination. Mary, do you have any thoughts on that?
First of all, I think it's really good that services who only in the past worked with people with dementia and dysphagia are now starting to be able to offer support to people who are also affected by communication difficulties. As communication professionals, it's really important that we can use all of our skills to meet all of the needs that people with dementia are experiencing. My experience is if you can start to provide some advice and support and assessment and input to people around their communication needs as well as their swallowing needs, the multidisciplinary team will find that input useful and will start to refer more patients. But from the start, people won't always understand what the full role of the speech and language therapist is in quite a new area. And then you also asked about whether this is discrimination if we're only offering support to people who have one sort of organic brain disease, for example, a stroke or a head injury, versus people who have another sort of brain disorder, as in dementia. And I think, yes, that is discrimination. I feel very uncomfortable with that.
Okay, thank you very much for that. We also had several questions which related to dementia and learning disability, reminding us that people with Down syndrome may develop dementia at a younger age, and asking how we ensure that dementia services make reasonable adjustments for younger service users, asking also about community learning disability services. And Sasha, do you have anything to say on that?
Right. So when you are providing services to someone with learning disability who has a new diagnosis of dementia, I would say that you provide sort of the same kind of approaches and strategies that you would with someone without learning disabilities and who has dementia. Usually someone with learning disabilities will often have communication strategies in place and may already have some support in place in their environment, but it's really important to find out how they were communicating before their dementia, and really working with using those strategies and methods that work for the person sort of throughout their life until the dementia. So some of the things that you can do, which are some of the, similar to ideas that you can use with people who have just dementia on its own, are ensuring that you're establishing routines and sticking to those routines, keeping a calm environment, calming activities to reduce agitation, carrying out activities that the person enjoys, especially if their memory is impacted, like reminiscence therapy, and of course implementing clear communication strategies as well.
Okay, thank you very much for that, Sasha. I can see a couple of questions now coming in live, and we'll move to those in a moment. Sasha, we just had one more which I wanted to ask you, which was around the mix. How can we manage the mix of people with dementia on wards with, and this is pushing inverted commas, functional patients? Any comments on that?
Yeah, that's something that actually people bring up a lot with me. You know, having worked in a dementia role in a hospital, and in a hospital with a large proportion of our patients with dementia. We had patients with dementia on every ward, so from orthopedics to A&E to surgery, the medical wards. There's patients with dementia intermixed with patients without dementia throughout the hospital, and that's one of the realities of the hospital. So some of the things that we can do in the hospital is we can adapt the environment for patients with dementia, and we can implement programs such as forget-me-not scheme, that kind of thing in the hospital. We can place patients in wards so that they can view the toilets, so that they can view clocks, and you know, place them near the nursing station if that's applicable. Ensure that they have lots of activities during the day to ensure that they have calm nights. And essentially, good dementia care is just good patient care. So if you're implementing these strategies throughout your hospital, all patients are going to benefit from the strategies.
Okay, thank you very much, Sasha. Questions that are coming in online. There's a particular one around numbers. Does RCSLT provide guidance on ratios of SLT per patient population? Now, this is a question that comes up a great deal in different areas of service provision. I think what I'm going to do, the person who's asked this, I think we're going to contact you after on this one because the answer is quite complex and possibly not amenable to a quick reply here. So we'll get back in touch with you after the webinar on that. A couple of others that have come in, and my colleagues will just take a little look. But I noted that we've had one in around, given commissioners not currently commissioning sufficient services in a number of SLT areas, what evidence is there that dementia is getting or will get sufficient SLT provision? Now, obviously, and I'm aware that we have colleagues on from Scotland and places where commissioning is not an issue in the same way. Yes, it's true, and yes, a lot of what we're trying to do, for example, with the awareness campaign, is say, here's why this is important. But ultimately, it's going to be about a business case, and it's going to be about evidence of need. What we do know, of course, is that from the Prime Minister down, we're being told that dementia is a priority area. It's one of the few areas of commonality amongst the different political parties, and hopefully that can help provide the context for making a case for enhanced provision. But there's no doubt that there isn't enough speech and language therapy in the dementia field right now, and that's why the awareness-raising work we do along with the evidence base is so important. I just wanted to check with Mary and Sasha. The question around picture sets and boards, have either of you got a particular example you can offer on that? So the question was, Sasha, are there any picture sets or boards that can be used to enable service users with dementia to answer straightforward questions?
You know, I would say that it really depends on the person who you are communicating with. Some people find that having, you know, a picture there to sort of help with the context of a question is quite helpful and quite reassuring. I would say using picture sets or boards in combination with just really good communication strategies where you're implementing really great total communication, you know, from the words that you're choosing, the rate of speech, your body language, your facial expressions, and a mode of communication that the person is quite familiar with, in conjunction with, you know, maybe trialing using some pictures as support, might be a useful strategy.
Thank you, and thank you for those of you who have been commenting already that they found some of the ideas that Sasha and Mary have put forward to be helpful. While you're dealing with particular ideas, Sasha, there was one other question that had come in, quite specific, but around cognitive stimulation therapy and outcome measures. And I know you had one or two thoughts to offer on that.
Yeah, so cognitive stimulation therapy is basically just psychosocial therapy, and our therapeutic activities program for patients with dementia, I would say, is a form of cognitive stimulation therapy. Now, with people with dementia, a lot of emphasis has been placed on reality orientation as part of cognitive stimulation therapy, and that was a part of our program. But I would say a lot of the sort of cognitive communication activities that we did were, would also be considered a form of CST, like reminiscence therapy, singing for the brain, finish that line, those kinds of activities. And the outcome measure that we used was a mood and well-being sort of Likert scale type of questionnaire where the person conducting the activity, whether, a member of staff or a volunteer, would rate the person's mood before the activity as well as their own mood, and then after the activity also rate the patient's mood as well as their own mood. And we found that that was quite a simple way of tracking participation in activities, but also tracking how the activity or how the therapy impacted how the patient was feeling.
Okay, thank you very much. And the last question that I've got at the moment, unless people come in quick, is actually around campaigning, around giving voice. And the question was, how can speech and language therapists who don't work with adults support and promote the importance of our role in dementia care? And I think that is important. Clearly, those of you who work directly with people with dementia or in adult services are going to be closer in and more likely to organise things like visits for dignitaries or events specifically around our role in dementia. But there's definitely a wider role for those of you involved in giving voice and campaigning. For example, social media and promotion around Twitter and Facebook. For example, if you're doing general giving voice awareness events like the one I'm going to very soon in Sheffield, which will focus on all of our current priorities, there's a role there at the moment for making sure dementia is part of that general pitch. And thirdly, we're quite soon going to be asking you to approach all of the candidates in the general election that's coming up to talk about the importance of speech and language therapy. And we'll want you to include our role in dementia as part of that. Now, questions have just come in quickly, and I'm going to be reading this live. The team is lucky enough to have counsellors who specialise in working with people with dementia and other neuro. Is there any evidence of the benefits of this on a wider scale? Interesting one, on which we will return to you. The last one is much simpler, which is, will the slides be available to view after this presentation? And the answer is, yes, they will. They'll be going up along with a full recording of the event. I can also see that someone said, could we have a reading list if possible? And I'm getting a nod for that too. I think some resources already available on the website. So, we're coming to a conclusion. Here's some more facts just to sign you off. With thanks to Derbyshire. The chance of developing dementia increases with age. But here's what's interesting. 1 in 6 people over 80 has dementia, more common amongst women than men. But here's an interesting one, particularly if you're meeting politicians. Dementia costs the economy $23 billion a year, more than cancer, stroke and heart disease combined. So we hope that you have found today a useful introduction to this area. We hope that you'll engage with what the Royal College is doing in terms of evidence, in terms of practice, and in terms of campaigning. I'd like to thank Mary Heritage and Sasha Wade for their time and for their expert input. I'd like to thank all of you for being on the webinar and participating. We look forward to you joining us on another webinar soon. Thank you and good afternoon.